What's up, Ninja Nerds? In this video, we're going to be talking about subarachnoid hemorrhage. But before we get started, please support us. And the best way that you guys can support us is by hitting that like button, commenting down in the comment section, and most importantly, subscribing. All right, Ninja Nerds, let's get into it. All right, Ninja Nerds, so let's talk about what the heck is a subarachnoid hemorrhage. It's very simple. It's a hemorrhaging of the cerebral vessel, primarily of the vessels of the circle of Willis, into the subarachnoid space. That's all it is. Now, sometimes it's very important to remember, though, that those circle of Willis or the cerebral vessels, not only can they rupture into the subarachnoid space, but they can also rupture into the ventricles as well and cause intraventricular hemorrhage. And we'll talk about that a little bit later. But basic concept, cerebral vessel ruptures into the subarachnoid space. That is a subarachnoid hemorrhage. Now, what's the causes of this? The first and easiest one, and the most common type, is traumatic. So there's some type of trauma, and there's two types of trauma. There is blunt force trauma. So you basically get hit over the head with a bat, or you have penetrating trauma. So maybe you got jabbed in the head with a knife. Okay, not funny, but either way, one of these two things lead to the injury of those cerebral vessels. They rupture into the subarachnoid space, causing a subarachnoid hemorrhage. By far one of the more common causes. The less common causes is non-traumatic, and there's actually kind of like two particular types there that I want us to focus on. One is aneurysmal, and that's what we're going to talk about real quick. So there's some type of aneurysmal cause. Now, the first thing that we need to talk about here is aneurysms. There's actually a bunch of different types of cerebral aneurysms that you could form. What are these different types of cerebral aneurysms? The first one that I want you guys to be able to recognize here is whenever you have this asymmetric. So imagine this little bump here is not present. So just imagine that's gone for a second. Whenever you have kind of a ballooning or outpouching of the vessel that's asymmetric, it's not the same on both sides, that's saccular or a berry aneurysm. So we call this one a saccular aneurysm, also referred to as a berry aneurysm. Now, this one is a saccular or berry aneurysm, but sometimes we call them giant saccular or berry aneurysms. We just like to add on to it. So this one is a saccular aneurysm, but we just add on the term a giant saccular aneurysm whenever it's greater than 2.5 centimeters. So either way, we can call this a saccular aneurysm, but if it's greater than 2.5, we just call it a giant saccular aneurysm. The other type of aneurysm that you can get, which is less common, is this type where you have symmetrical outpouching or dilation of the actual cerebral vessels. And this is called fusiform. So fusiform aneurysm, or dolichoectatic, not writing that out. So fusiform is a symmetrical dilation of the cerebral vessels. The next one is actually not a true aneurysm. We actually call it a pseudoaneurysm, but really it's a dissection of the vessel, and that dissection creates what looks like an aneurysm on imaging, but it's not a real aneurysm, it's a false aneurysm, so we call it a pseudoaneurysm. Okay, very important. So the reason why, really quickly here, is let's imagine blood flow is running through this vessel, and as it runs through this vessel, it tears through the intimal lining. So you have a tunica intima or interna, tunica media, tunica externa. If the blood slices and dices through that tunica intima or tunica interna and accumulates here inside the actual, between the media and the intima, it can kind of create an outpouching that is filled with blood that looks like an aneurysm. But it's not. It's a pseudoaneurysm because there is a hole within the vessel wall that is allowing blood to accumulate in the vessel wall. Okay, it's not a true aneurysm. So that would be a dissection, also known as a pseudoaneurysm. The next type here that I want you guys to remember is actually kind of what looks like maybe a saccular aneurysm, but it's actually infected. It contains infectious material that is within that aneurysm. And we call these mycotic aneurysms. And so I just want you guys to remember kind of infectious in nature. Okay? So big different types of aneurysms you have. Saccular aneurysm is the most common. That's also known as a berry aneurysm. Fusiform, also known as dolichoectatic, less common. Dissections are pseudoaneurysms, and then finally mycotic or infected aneurysms. Now, These are the different types of aneurysms you can have. Now, the first question that we should have is, how do we form these aneurysms? And then what causes those aneurysms to pop and rupture and bleed into the subarachnoid space? So the first thing that you guys want to remember is that there's some type of stress on the vessel wall. And so what happens is if you have increased stress, and we'll talk about the different types of stressors, if you will, that increased stress can actually weaken the vessel wall. And we'll talk about how it actually does that in a second. So increased stress on the vessel, whether it be direct or kind of indirect mechanism, weakens the vessel wall. As you weaken it, you increase the risk of it dilating and then popping. The first one that I want you guys to remember here is hypertension. So hypertension is a very big one. The other one that I want you guys to remember is something that can kind of act like hypertension, and this is sympathomimetics. What the heck is this? This is things like cocaine, methamphetamines, things that basically increase your sympathetic nervous system. Okay? The other ones are smoking. So smoking, nicotine, all that good stuff. The other one here is ethanol. So these are some of the big things to think about is hypertension, sympathomimetics, smoking, ethanol. One more that I want you guys to remember here is oral contraceptives, or we can even add on here pregnancy. Now let me explain how these things actually do this. The big thing to remember is hypertension. So hypertension can actually cause, you have all this high blood pressure. So hypertension, sympathomimetics, smoking, oral contraceptives, all of these things can actually increase your blood pressure. And as you increase your blood pressure, you put lots of stress on these vessel walls. Over time, that can actually weaken these walls, making them more susceptible to becoming dilated or having these outpouchings. The second way that this can happen is hypertension and some of these other things here can act on these tiny little vessels that supply the tunica media of the vessel wall. You know what these little vessels are called that supply the tunica media? We call that the vasa vasorum. So what happens is you know what hypertension or sympathomimetics or smoking or ethanol or oral contraceptives in pregnancy can do besides increase your blood pressure, putting stress on the vessel wall? It can also make these tiny little vessels of the vasa vasorum become arteriosclerotic. It can cause hyaline arteriosclerosis. And as you cause that hyaline arteriosclerosis, that affects the blood flow to the tunica media. So what can happen here? You can develop what's called hyaline arteriosclerosis. And what happens is you actually kind of like cause these little like plaques to develop within these tiny little vasa vasorum vessels. As those plaques develop, you decrease the blood flow to the muscle, the tunica media of the vessel. And then that muscle, if it doesn't get oxygen, it dies, and then you start causing weakening and ballooning and dilation of those vessels. So that is what happens, and that's what I want you guys to remember. So big quick recap here. What things can increase stress on the vessel wall, weakening it, increasing the risk of dilation of it? Hypertension, sympathomimetics like cocaine, methamphetamine, smoking, ethanol, oral contraceptives, or pregnancy. Either direct shearing forces on the vessel wall, putting stress on it, weakening it, or causing hyaline arteriosclerosis of those vasa vasorum vessels, decreasing blood flow to the actual tunica media, causing the tunica media to die, and then leading to weakening of the vessel wall. Okay? That's the big one there. The next causes that I want you guys to be thinking about is going to be something that actually causes a genetic, usually genetic causes. That is actually, there is a weakness in the vessel wall because of a connective tissue defect. So there's actually some type of connective tissue defect. And because of that, connective tissue is very important for the entire structure of the vessel wall. If you have a defect within that connective tissue, that can weaken the vessel wall. If you weaken the vessel wall, it's prone to forming dilation, outpouching, and then rupturing. What are the different types of connective tissue defects that you guys should be thinking about? One, the very important one here, is going to be Marfan syndrome. So Marfan syndrome is actually a deficiency or absence of the protein called fibrillin, which is important for the elastic laminas. The other one is called Ehlers-Danlos syndrome. And then Ehlers-Danlos syndrome is actually a deficiency within collagen, which is again important for that tunica media. Okay, so collagen is deficient. And then the last one here is called polycystic kidney disease, which is an autosomal disorder, usually the autosomal dominant type, which is there's usually a defect within the polycystin proteins, which are also incorporated into the vessel wall. The whole basic concept is if these proteins aren't there, you don't have a structural integrity of that vessel. The vessel structure is very susceptible to dilation, outpouching, and then popping. Okay? All right, so the next thing that we want to remember besides direct stress, connective tissue defects, is there's another type of genetic cause where there's abnormal growth, dysplasia, if you will. So there's abnormal growth or dysplasia of the smooth muscle within the vessel wall. So dysplasia of smooth muscle. And what does the smooth muscle make up within the vessel wall? The tunica media. If there's dysplasia of the actual smooth muscle, this can lead to particular weakness in particular areas of the vessel, which make it more susceptible to forming outpouches, dilations, and then popping. What is this called? This is called fibromuscular dysplasia. This is a genetic condition. Usually, it's more evident at older ages because it takes time for it to actually start to develop and cause problems like subarachnoid hemorrhages. But basically think about it like this. What is dysplasia? How do you determine it again? Pleomorphism. You make different smooth muscle cells, in this case, dysplasia of smooth muscle. So some smooth muscle cells are big, some smooth muscle cells are small. So in areas where the smooth muscle is less, maybe that area where there's less smooth muscle is more susceptible to dilation or outpouchings. And so areas here you'll have outpouches, and then other areas where the smooth muscle is really thick, you have increase in smooth muscle size. Those will actually be kind of like thickened areas. So fibromuscular dysplasia is this different kind of formation of smooth muscle cells, some big, some small, in different shapes and sizes that increase the risk of forming thin layers and thick layers, and that is called fibromuscular dysplasia. These vessels are outpouches, they're thin, the wall's thin, it's very susceptible to a change, like a brief rise in blood pressure that'll pop these things and lead to a cerebral aneurysm that ruptures. So that is the next one there that is a genetic cause. Again, fibromuscular dysplasia, pleomorphism of the smooth muscle walls. Some areas are thin, which can dilate, and some areas are thick. The last type of cause here is related to this last one here, the mycotic aneurysm. So in another condition where someone can have what's called infective endocarditis. Infective endocarditis. Infective endocarditis is usually wherever somebody has an infection of their endocardium, and they form these little infective kind of vegetations, usually on the valves of the left side of the heart, usually the left atrium. But it could be the right atrium if it's tricuspid valve. But if it's mitral valve involvement or aortic valve involvement, you'll form these little vegetations on those valves. And what happens is if these vegetations that contain a lot of infected material break off and they flow up through the left ventricle into the aorta, through your cerebral circulation, and then guess what? These little infective materials get stuck into these vessels and start actually degrading away at those vessel walls, degrading them, making them very thin, increasing the risk of these outpouching. And then what happens? A change, brief rise in blood pressure, you pop those suckers. So again, infective endocarditis is a condition where you have infection of vegetations that form on usually the valves that break off these little things called septic emboli that get stuck in cerebral vessels, infecting the vessel wall, making it thin, making it susceptible to dilation, outpouching, and popping. That covers the basic things that I want you guys to know as risk factors, causes, and the basic pathophysiology of aneurysms. The next thing I want to talk about is we have a reason for these aneurysms forming, right? Big quick recap: stress on the vessel wall, hypertension, ethanol, sympathomimetic, smoking, OCPs, pregnancy, connective tissue defects like Marfan, Ehlers-Danlos, polycystic kidney disease, fibromuscular dysplasia, and lastly, infective endocarditis. These are some of the reasons we can form aneurysms and how we have an increased risk of those aneurysms rupturing. Where can these aneurysms form within the circle of Willis is another very, very important point that we have to talk about. So where are the most common locations where these aneurysms that we talked about, with the most important one being saccular, where can they form? The first area that I want you guys to remember here is going to be the anterior communicating artery. So the first one, which is the most common, is called the anterior communicating artery. This one actually accounts for up to 30% of the saccular aneurysms or Berry aneurysms. So that would be this one, okay? The second one that I want you guys to remember is the posterior communicating artery. So the posterior communicating artery is another big one, and this one accounts for about approximately 25% of the different types of saccular cerebral aneurysms. The third one is the MCA, usually where it bifurcates. So wherever it bifurcates is a very high risk spot. So what's called the MCA bifurcation. This one accounts for about approximately 20% of these cerebral aneurysms. The fourth one that I want you guys to remember is right here. What's this structure here called? This is your internal carotid artery, the terminus of it, as it gives way to the ACA and the MCA and the PCOM. So the ICA terminus accounts for approximately 7.5% of the saccular cerebral aneurysms. The next one is number 5. What is this vessel here? This is the basilar. It comes all the way up here and gives way to the PCA. The basilar tip is another common location. So the basilar tip accounts for about 7% of the cerebral aneurysms that you can form. What else do we have? Well, think about what else do we got left here. The next one is this guy up here, 6. That's the anterior cerebral artery. So the anterior cerebral artery accounts for about approximately 4% of the actual cerebral saccular aneurysms. And the last one is this tiny little guy coming off of your vertebrals, your pica. So that's the last one, which is going to be the pica, and that counts for about 3.5% of your cerebral aneurysms. The rest of them that makes up the last of the 100% is different miscellaneous locations that we're not going to talk about. So big thing to remember, if somebody asks you what is the most common location for these aneurysms to form and pop, you would say anterior communicating artery. Someone said the second one, you would say the PCOM. Someone said the third one, you'd say MCA bifurcation. Those are the big 3 that I want you guys to remember, okay? So we know now the types of aneurysms, the causes of it, how those causes lead to aneurysms, and we know where those aneurysms can form, most common locations. The last thing that I want us to discuss is what is the reason why someone will actually pop these aneurysms. So in other words, we know the cause of them, what forms them, where they form, but what causes them to eventually just rupture all of a sudden? And that's a nice little discussion that we should talk about. So the next little thing is, what's the trigger? And it's actually not that hard. Thank goodness it's a very simple, straightforward thing. What is the trigger? And really, the most common trigger is an acute rise in blood pressure. That's going to be probably one of the most common causes. The other one is some type of painful stimulus. So maybe they have a painful stimulus of some kind. And the last thing is they have some type of anger fit. These are kind of the big reasons why someone would actually have an acute trigger to eventually rupture these aneurysms that have been formed by the different reasons that we talked about how they form. Okay? So we got traumatic subarachnoid hemorrhages, we got aneurysmal subarachnoid hemorrhages with the different causes, different types of aneurysms, where they form, and what triggers them to pop. The last thing I need you guys to remember is what is the last potential cause of a non-traumatic subarachnoid hemorrhage. And that last one is called an arteriovenous malformation. So an arteriovenous malformation. We also call these AVMs. What's important to remember is that these are common usually in children. So children, adolescents, younger individuals that we would see this more commonly in. What is an AVM and how does this actually become a problem? Well, usually whenever you have a arterial, so this is actually what's called an arterial, right? An arterial will feed into what's called a venule via what's called a capillary bed. So it'll actually branch off into these different capillaries that'll come back into the venule. When someone has an AVM, they don't have a true capillary. So there's actually no true capillary here. So no true capillaries. They just form kind of a direct connection between the arterial and the venule, which leads to this big old nidus that you see here, this big old ball of vasculature. This big old ball of vasculature is very susceptible to acute brief rises in blood pressure, things like that, and that sucker can pop, leading to a subarachnoid hemorrhage. Okay? So those are big things to remember here. Okay, we talked about the causes, we talked about the pathophysiology of these different things with subarachnoid hemorrhage. The last thing that I want to talk about is going to be discussing a little bit more of the clinical features and the treatment. So when we talk about subarachnoid hemorrhage, where is the subarachnoid space where the blood accumulates? Well, if you guys remember, what is this part here? This black layer is the brain tissue. There's a piece of tissue that we're not showing here, but it clings to the actual brain. It's called the pia mater. Then there's another one, this blue layer here that looks like a spider. That's called the arachnoid mater. Then you have this kind of like maroon colored one, which is just outside of the arachnoid mater. That's called the intermeningeal layer of the dura mater. And then you have this green layer, which is the most outer part of the dura mater, called the outer periosteal layer of the dura mater. The subarachnoid space is located between the pia mater and the arachnoid mater. So what runs in this area? If you imagine here, let's say here's your anterior cerebral artery, it runs within that subarachnoid space. If you pop one of those aneurysms, the blood will accumulate here in all of this subarachnoid space, and that's where it can actually accumulate and form all that bloody area. The other thing that I want you guys to remember is that sometimes you can actually have these aneurysms rupture, that not only does it fill within the subarachnoid spaces, but the blood can actually extend into the ventricles. If blood extends into the ventricles, why is that a problem? And I really want us to think about this logically. Where does CSF flow? Let's see if you guys remember your anatomy and phys of the CSF system. It would start over here from your lateral ventricles, and they would come down from the lateral ventricles into the third ventricle. From the third ventricle, it run down through the cerebral aqueduct and then into the fourth ventricle. Then from the fourth ventricles, it would run over here into the subarachnoid space via the lateral apertures or the median apertures, or go down into the central canal. We know that's kind of the basic flow. What if I had a Hawking clot there from that blood from the subarachnoid hemorrhage that got stuck in the third ventricle? Could the CSF move from the lateral ventricles into the cerebral aqueduct? No. And if the CSF can't move here, what's going to happen to the size of these ventricles? They're going to get bigger. They're going to balloon up because of that backflow. And as they balloon up because of that backflow, what is that called? Hydrocephalus. So what I want you guys to remember is that a subarachnoid hemorrhage can lead to what's called an intraventricular hemorrhage. That intraventricular hemorrhage can lead to hydrocephalus. But here's the next thing. If the blood accumulates within the ventricles, that's called a hydrocephalus, right? Because it's obstructing the CSF flow. There's two different types of hydrocephalus. One hydrocephalus is actually due to an obstruction of blood flow. That's called the obstructive type. That's the one we just discussed. But there's one other type. You know, if you have blood within the subarachnoid space, you know there's these little thingies here, these little things called the arachnoid granulations or the arachnoid villi. They suck some of the CSF out of the subarachnoid space and then put it into the things called the dural sinuses, right? We know those structures. We know that from our anatomy. If there's a lot of blood within the subarachnoid space, these arachnoid granulations, they get stuck They're trying to pull all the CSF, but they're getting stuck and fill it up with blood. And so they're not going to be able to drain that CSF as well. And so what happens is the CSF that's not getting drained into the dural sinuses starts backing up in the same way. So backing up from the subarachnoid space, backing up into the ventricles, and causing hydrocephalus. What's that type of hydrocephalus? Very important name. That's called a communicating hydrocephalus. So it's a hydrocephalus, but it's a problem with the communication between the subarachnoid space and the dural sinuses. So we call that a communicating hydrocephalus. The reason why this is important is that the obstructive one is usually more acute. The communicating is a little bit more chronic. Okay, important thing to remember. So that is the last part of the etiology and pathophysiology that I want you guys to remember for subarachnoid hemorrhage. Now, let's talk about the clinical features. All right, Ninja Nerds, now let's talk about the clinical features of subarachnoid hemorrhage. So the big thing to think about here is whenever that blood's in the subarachnoid space, right? Whenever there's a rupture of the actual subarachnoid, whenever there's a rupture of those cerebral vessels, what happens is it can irritate the meninges. Whenever it irritates the meninges, it can do two particular things. What are those things that it can do? The first one that I want you to remember is when it agitates the meninges, there's a bunch of different cranial nerves, including the trigeminal nerve that supplies the meninges. If you agitate those meninges, it's going to activate the trigeminal nerve. Whenever you activate the sensory fibers of the trigeminal nerve, it can lead to the sensation of headaches. So one of the big kind of symptoms that you're going to see is a headache. And what's really important, what you guys need to remember, is that this is kind of like the worst headache of the patient's life. We also kind of use the term thunderclap headache as a pathognomonic sign of someone having a subarachnoid hemorrhage. The other thing that you want to remember is that whenever the blood's in the meninges, it agitates the meninges, irritates them, and can produce particular types of meningeal signs. What the heck does that mean? So you know whenever someone has meningitis, there's particular meningeal signs that we can see with those, and those include photophobia, so significant sensitivity to light. They can also have neck stiffness or nuchal rigidity, and they can also have those positive kind of physical exam tests that you could do, which is called a positive Kernig's or a positive Brzezinski's. Okay? That's kind of the big thing to think about. So again, thunderclap headache, worst headache of their life, meningeal signs. The other thing that you guys need to be thinking about with this one is that remember the Monro-Kelly doctrine. The Monro-Kelly doctrine says what? As you have inside of the skull, blood, CSF, brain tissue. If one of those increases, the skull can't expand. And so what happens is the intracranial pressure increases when one of those things increases. So in this case, what's increasing inside of the skull? Blood. So because of that, these individuals can also develop increased intracranial pressure. And increased intracranial pressure also can present with headache, but it also can present with nausea, vomiting. It can present with cranial nerve deficits like a blown pupil. And also it can present with posturing. So maybe they have decorticate, maybe they have decerebrate posturing. And it also can present with just very high yield for your exam, Cushing's triad, which is a classic sign of increased blood pressure, low heart rate, and irregular respirations. Okay, so this is kind of the classic things to be thinking about here. The last thing that I want you guys to think about is that, for example, if the anterior communicating or the MCA vessel ruptures, the blood flow that's going to be going to the particular part of the brain is now lost, and you can't supply blood to that part of the brain. So what could you develop? Stroke symptoms. And so another thing to be thinking about in these patients is that they can also develop focal deficits. And so it may present like a stroke syndrome. And that's where you guys need to go watch our video on stroke syndromes if you guys aren't completely familiar with all of the different types of stroke syndromes. That'll help you with that. Okay? So those are the basic clinical features to think about. Again, what are they? Worst headache of the life. Meningeal signs because of agitation of the meninges. Photophobia, what else? Neck stiffness, nuchal rigidity, positive Brzezinski's Kernig's. Also increased intracranial pressure because you have more blood in the cranium. So that's going to present with nausea, vomiting, cranial nerve deficits, posturing, as well as the Cushing's triad. And finally, depending upon the vessel that's affected, you may not supply a part of the brain, leading to particular focal deficits like stroke syndromes. All right, so the last thing that I want to talk about with clinical features is a thing called the Hunt and Hess score. So the Hunt and Hess score is really important because what it tells us is mortality. You know, a subarachnoid hemorrhage is a pretty serious condition. And so we utilize the Hunt and Hess score not to prognosticate initially, but to get a good idea of what's their risk of dying. So if someone comes in and they're completely asymptomatic, that could be a potential score of 1. But it also could still be a score of 1 if they have like a very mild headache and maybe even some nuchal rigidity or some neck stiffness. Okay, so these are things to be thinking about. They can get a score of 2 if their headache is a little bit more moderate to severe. And not only do they still have nuchal rigidity, but they also have cranial nerve deficits. So maybe one of their pupils is unequal, okay? 3 is they're coming in and, you know, they're a little bit like lethargic, okay? They're a little lethargic. Maybe they're even a little confused. So maybe a little lethargic, maybe a little confused on their mental status exam, but they also have focal deficits. So maybe they have weakness in one of their arms or one of their legs, okay? And the next one here is that they're stuporous, or maybe they're obtunded. So you're having to give them repeated stimulation, having to maybe say, hey, John Doe, wake up, wake up, wake up, or apply painful stimulus, hey, wake up, wake up, wake up. They do wake up, but it just takes a lot of stimulation to get them up. And if they are showing early signs of posturing, maybe they're decorticate posturing, maybe they're having early signs of decerebrate posturing. So this could be a bad sign and a score of 4. All right, the last part of the Hunt-Hess score is going to be a score of 5, which is the worst case scenario, very high mortality rate. If you're applying painful stimuli, lots of painful stimuli, and they're not arousable or alert whatsoever, they're in a comatose state, right? And then the next thing is if they're posturing, you apply painful stimuli and they start having this abnormal kind of extension posturing, and they start coming in like this, adduction extension posturing, that's called a decerebrate posturing. Okay? And again, this would be the worst case scenario. So high mortality rate at this level. Okay? So that covers the basic clinical features. Now let's move on to the diagnostics. All right, so we have the basic idea of the clinical features, right? Headache, meningeal signs, increased ICP. We also have those focal deficits, and we went through the Hunt and Hess score to determine the rate of mortality. Now we have to diagnose these conditions, right? We got to figure out, do they have a subarachnoid hemorrhage? How do we do that? The first thing that you're going to want to obtain is a non-contrast CT scan of the head. And what are we looking for? Well, subarachnoid hemorrhage pattern is very kind of classic generally. You would see blood white on the non-contrast CT scan that would show up in a couple different areas. One is they could show up in the sulci, so in the little ridges between the gyri. They could also show up in the cisterns. There's different types of cisterns where it can become very evident. It also could show up, where else? It could also show up in the ventricles. Sometimes you can get extension of that bleed into the ventricles causing IVH. Another thing to be looking for is if there is blood in the ventricles, is it enough that it actually is causing the ventricles to puff up? In other words, are those ventricles dilated, and do they have hydrocephalus? And what are the different types of hydrocephalus? The acute one would be an obstructive hydrocephalus. The chronic one would be a communicating hydrocephalus. So that's the big thing that you want to look for with the non-contrast CT. Now, if you see a subarachnoid hemorrhage type of pattern on the non-contrast CT, what you can do is you can start actually giving a score based upon that non-contrast CT called a modified Fisher score. And what a modified Fisher score does is it determines the risk or the rate of developing what's called vasospasm, which can lead to what's called delayed cerebral ischemia. So it's indicative of their risk of developing vasospasm. We'll talk about that. It's one of the second most common causes of mortality in patients with subarachnoid hemorrhages. So how do we kind of grade like the modified modified Fisher score based upon the CT scan. We have a couple different grades. You have 1, 2, 3, 4, and it's really actually pretty simple. It's if you have a thin subarachnoid hemorrhage, and we classify that by less than 5 millimeters, and no IVH. So you have the subarachnoid hemorrhage in the sulci and the cisterns, but it's less than 5 millimeters. There's no IVH or hydro. The next thing is 2. So thin subarachnoid hemorrhage, still less than 5 millimeters within the sulci and the cisterns, but you have IVH, maybe with some hydrocephalus. 3 is you have a thick subarachnoid hemorrhage within the cisterns and the sulci greater than 5 millimeters, and you have no IVH. And then in this case, 4 would be you have a thick subarachnoid hemorrhhage greater than 5 millimeters within the cisterns or the sulci, and you have IVH present. Okay, that is the modified Fisher score. It determines the risk of vasospasm or delayed cerebral ischemia based upon the non-contrast CT. Now, let's say you get the non-contrast CT, you see subarachnoid hemorrhage blood pattern as we described above. What's the next test that you would do? A good test is a CT angiogram of the head and neck, because it gives us a look at the vessels to see, is there a part where there's an aneurysm that actually ruptured, because maybe we can find the aneurysm. So that's where a CT angiogram can come in nice and handy, is we're looking at, so this actually helps us to identify the actual vessel aneurysm, okay? So that's one reason we can do this. It can help to identify the vessel aneurysm. Now, there's one problem with this, is that sometimes it can be missed if the aneurysm is less than like 3 millimeters. Sometimes they even say potentially 4 millimeters. If it's smaller than that, the CTA might not be able to pick it up. Another thing with the CTA, besides identifying the vessel aneurysm, is it can help to distinguish a very particular type of presentation that's very similar to subarachnoid, what's called RCVS, reversible cerebral vasoconstriction syndrome, also known as Fleming syndrome. In reversible cerebral vasoconstriction syndrome, they can present with kind of a subarachnoid hemorrhage pattern on their non-contrast CT and their clinical features. But in RCVS, they actually have, whenever you get the CTA, it shows areas of kind of like stenotic areas. So it would show stenotic or narrow areas for RCVS, whereas you would see the actual aneurysm that ruptured in a subarachnoid hemorrhage. The other thing to be thinking about with the CT angiogram is just remember, consider the risk of what's called contrast-induced nephropathy. Whenever you give contrast, if a person has a very low GFR, glomerular filtration rate, they have a high creatinine, you can actually injure their kidneys and cause an acute kidney injury from the contrast. So again, something to think about when you're doing a CT angiogram. Okay? So we got a non-contrast CT, found the subarachnoid hemorrhage pattern, used it to determine their risk of vasospasm within the future, used the CTA to find the vessel that actually did rupture or distinguish it from RCVS. What's another test that we can do? If we want to go straight to the gold standard, baby, the best test that you can do is what's called an angiogram, a digital subtraction angiogram. This is the gold standard test. This will give you direct visualization. So visualization of vessels in a three-dimensional image. So this is a real-time kind of look at the vessels. It's kind of the gold standard. You get a very good look at those vessels and see if you can find any aneurysms, any dissections, any AVMs, so on and so forth. So it's definitely the gold standard. But again, with this, it's kind of invasive. You're actually threading catheters up through the veins and filling them with contrast so that you can visualize them on these studies. And so there is risk of puncturing an artery, causing like a retroperitoneal bleed if they come up through the femoral structure, or kind of dissecting cerebral vessels. So there is complications. The other nice thing about this is that it can also be utilized as therapeutic. If you're in there finding the vessel that has an aneurysm, you can then just go ahead and coil it, which we'll talk about a little bit later. Okay? The next thing that you can do, let's say that you get a patient with a CT, they don't show that classic subarachnoid hemorrhage pattern, but you have a high suspicion. You get a CTA, it doesn't really show it. Then you still have this high suspicion. I still think that they have a subarachnoid hemorrhage. And you just didn't get the angiogram yet because you don't want to risk it. You can do a lumbar puncture. So a lumbar puncture, remember the subarachnoid space isn't just within kind of the brain and brainstem area, it also extends all the way down that spinal cord, right? And so what we can do is we can take and tap into the subarachnoid space near the lumbar area, L3, L4 interspace. Take some of the CSF and guess what's going to be in that subarachnoid space? Blood if you have a subarachnoid hemorrhage. So if you do a lumbar puncture, what are some of the things that you may pick up in this? One is that the test tubes will fill with blood. And what's important to remember to distinguish this, is it a traumatic tap or is it actually a true subarachnoid hemorrhage, is as you fill these vials up, they'll stay pretty bloody and the same kind of bloodish hue throughout every single kind of test tube. The second thing that you can do is after you take and accumulate these actual test tubes and send them to the lab, they'll do what's called a centrifuge. And after you centrifuge these, it actually causes some of the heme within the red blood cells to break down and give off this yellowish hue to the actual test tube, which is called xanthochromia, which is very highly sensitive and somewhat diagnostic of a subarachnoid hemorrhage, okay? So these are the quick little things that you can do. Now that you've diagnosed a subarachnoid hemorrhage based upon any of these measures, if you want to figure out the underlying etiology, you have to think about those causes. So hypertension, did they come in hypertensive? Was there trauma? Were they on drugs? Get a tox screen. Do they have genetic causes? Test for underlying genetic conditions if you suspect it. Do they have fibromuscular dysplasia? Angiography can show that. Also get like a renal ultrasound. So thinking about the particular cause is other things that you can add into your diagnostic steps. But at this point, we've diagnosed a subarachnoid hemorrhage. Let's now start talking about how to treat it. All right. We're at the last part here, Ninja Nerds, of subarachnoid hemorrhage, and probably one of the most important parts, treating these patients. So this is a very significant condition. When someone comes in with a subarachnoid hemorrhage, it's considered to be kind of a neurological emergency. And so in that kind of situation, what is the most important thing to do in an emergency? Airway, breathing, circulation. That is the most important thing right away, and then we'll talk about some of the other interventions. So airway. Why would the airway become a problem? Think about this, Ninja Nerds. If you guys have someone who has a pretty decent sized bleed, what does that do to the intracranial pressure? It increases the intracranial pressure, right? And so you start putting injury and compression onto the brainstem. What does the brainstem do, especially in the pons and medulla area? It controls your respiratory center, and the respiratory center is what helps to drive the muscles that are involved in breathing. If you have high intracranial pressure and you're pushing down on that brainstem, it can decrease your respiratory activity. That's one thing to think about. We often use this kind of mnemonic of saying if their mental status is declining because of a large bleed, increasing the intracranial pressure, so high ICP, and decreasing the level of consciousness, we kind of use this thing saying GCS less than 8, intubate. So it's because we're worried about them not being able to protect their airway from that large bleed and high intracranial pressure. So that's one thing to be thinking about in these scenarios. The other thing to be thinking about is what if they're just generally hypoxic? So maybe if they're hypoxic, you can try particular types of measures like putting them on a nasal cannula. Oh, it's not working. Put them on a rebreather. Still not working. Putting them on high flow or CPAP, BiPAP. Still not working. Intubate. So again, if they're acutely hypoxic or refractory, so we put refractory hypoxia for whatever reason to all kind of non-invasive measures, you intubate them as well, okay? Now, once we intubate them and we protect their airway, there is particular ways that we should ventilate them that neuro patients usually benefit well from relatively two modes of ventilation. One is CMV, continuous mechanical ventilation. And what you do with this one is you hook them up and you actually control particular parameters. One of the common ones is volume control. And so you can set a tidal volume and you can set a respiratory rate which affects their CO2 and their pH. You also can control their oxygen status by controlling their FiO2, their percentage of oxygen, and their PEEP, how much you want to keep those alveoli stented open. And the last thing you can also control is how fast you want that air to run into their lungs, which is the flow rate, okay? So these are the things that you'll do with CMV. Once you set all these parameters, you modify things a little bit. So tidal volume and respiratory rate alters the CO2 and pH. FiO2 and PEEP alters your oxygenation. And those are things that you have to think about. How do we kind of monitor how well we're ventilating these patients? Well, you kind of monitor based upon their SpO2, okay, so their percentage of oxygen, as well as their ABG, if you're getting chest x-rays as well. That can also determine how well you're ventilating the patient, okay? Another mode that's really cool and is becoming a very hot one in neurological patients is called ASV, adaptive support ventilation. And with this one, you pick the % ventilation. You pick the FiO2 and you pick the PEEP, and then the machine figures out, based upon the lung mechanics of the patient, how well, what the patient wants and what the patient's able to do. It determines how much pressure you're going to push into their lungs, how much volume you're going to give them, how fast their respiratory rate is. It's all dependent upon the patient. It's called closed loop ventilation. And it's a very interesting way. One of the nice things about ASV is this allows for spontaneous breathing. Okay, so this allows for the patient to be able to take their own breaths and get what they need. CMV, you can do that, but it's preferable that you give them a very targeted amount of volume or a very targeted amount of pressure, and really you're trying to not have as much spontaneous breaths on those modes. And again, we'll have another lecture on that in the future. But big thing for airway, protecting their airway if they have decreased level of consciousness, refractory hypoxia due to the high intracranial pressure, 2 modes, CMV, ASV. ASV is a little bit more preferred. Next thing, we've sterilized their airway and their breathing. Circulation, that's what probably got them in this mess in the first place, is this high blood pressure, that acute rise in blood pressure. We gotta lower that blood pressure, baby. So let's lower it. How do we lower the blood pressure? And what's our goal, I guess, is the big question, right? So blood pressure control is very, very important. It's going to prevent that bleed from continuing to occur in that subarachnoid space. So what we like to titrate to is a systolic blood pressure pre-coiling or clipping, systolic blood pressure less than 160 millimeters of mercury. Okay, is the desired goal. After you secure them with a coil or clip, it's a little bit more liberal and you can kind of just change based upon what the patient needs. But the best things that you can do for this is very tight IV control medications. And I want you to remember nicardipine as a big one. This is a calcium channel blocker. It's going to vasodilate those vessels. That's an infusion. You have labetalol. Labetalol is an alpha and beta blocker, so it'll help with decreasing inotropic, chronotropic, and dilating vessels. Hydralazine is primarily a vasodilator, so it's going to reduce that afterload as well. Hydralazine would be the more preferred option if someone has a very low heart rate and you don't want to give them labetalol. And the other option is you can give them something called enalapril. And enalapril is basically a ACE inhibitor, and so it's going to allow for a vasodilation as well as reduced preload. And so that will be helpful as long as they have a normal kidney function and a normal potassium. Okay, so these are things to think about with blood pressure control. All right, ABCs are taken care of. Here's the next thing. There's a textbook on the neuro ICU stuff, and this guy named Lee said you should always think, especially with subarachnoid hemorrhages, ABC, EVD. So we've taken care of the ABCs. The next thing we should assess is, do we need an EVD, an external ventricular drain? Well, how do I know whether or not I need an EVD? If a patient comes in and their Hunt and Hess score is really bad, so maybe they're at like a 3, 4, 5 Hunt and Hess score, that's already kind of an indication of getting an EVD. So what are some of the indications? So indications primarily are dependent upon a couple things. One is a high Hunt Hess score. So if they have a high Hunt Hess score, they have a high mortality rate. So they probably need an EVD, most definitely. That's a big thing. The second thing is, do they have intraventricular hemorrhage? If they have blood in their ventricles, that's a problem. Why is that a problem? What can IVH lead to? Remember what I told you? If the blood gets stuck in the ventricles, can the CSF continue to flow? No. And so what's an issue with that? Obstructive hydrocephalus. And so these are potential indications for someone needing an EVD, okay? What are the benefits though? Why would I want to put an EVD into someone, and what the heck is an EVD? I actually should explain that, right? An EVD is a catheter that you kind of thread through the skull into the third ventricle generally, and it pulls off CSF and pulls off blood. So the benefit to that is that if someone has an IVH, so let's actually put here in a nice little different color here, let's put pink. If someone has an IVH, what the actual EVD will do is it'll take the IVH and it'll drain the blood from the ventricles, and that'll help to relieve the hydrocephalus. The other thing here is that it can actually decrease the ventricle size. And why is that a problem? Again, think about this, guys. Whenever you have inside of the skull increase in blood, CSF, or brain tissue, that's increasing intracranial pressures. If I pull blood out of the ventricles, that's going to decrease intracranial pressure. If I pull off some of the CSF inside of the ventricles, that's also going to decrease the intracranial pressure. So I'm trying to do these things, and by decreasing the ventricle size and pulling blood out, that's going to help with reducing intracranial pressure. Here's another thing to think about though, very, very important. Sometimes when people get an IVH, if they get an IVH that really clots. So now that blood that's sitting in the ventricles has been sitting there for a while, and now it's not actually allowing for any blood to be drained through the EVD. Holy crap, if I can't drain the blood from the EVD through the EVD, what's going to happen to their intracranial pressures? It's going to shoot up. So here's where you guys might have like an aneurysm thinking about this, but guess what we can do in these patients? We can actually put TPA into the ventricles to break up the clot. And if you break up the clot, you may be able to break it up enough to reestablish drainage through that EVD. And so sometimes whenever you have these, you utilize medications called intrathecal TPA that you will push through their EVD into the ventricles, breaking up the clot so that you can drain that clot. Very, very important. And it's only small doses and very localized. Another benefit to the EVD is it helps you to monitor their ICPs, which we can talk about here in a second. So it actually gives you real-time monitoring of their ICPs. And when we look at this, it's kind of in a graphic form here. You get this kind of like form here, where you look at a pressure waveform, a P1, a P2, and a P3, and it helps you to determine their overall intracranial pressure. Usually, ICPs are desirable to be less than 20 millimeters of mercury. If it's greater than 20 millimeters of mercury and it's sustained, that can be an ICP crisis, and that's what we'll talk about over here in a second, okay? So big things to think about. Indications for an EVD. High Hun-Hess score, IVH, hydrocephalus. Why? Drains the blood. If the blood's clotting, give them intrathecal TPA to help to break up that clot, reestablish the drainage, pull off CSF so that you can decrease the ventricle size, decreasing the hydrocephalus, and monitor their ICPs, because if their ICPs are rising acutely above this number and staying sustained, we can give medications to treat that. The last thing that I want you guys to think about is remember that last type of hydrocephalus that I told you guys about. So in someone who has kind of a communicating hydrocephalus, because that blood gets stuck in those arachnoid granulations, what can happen with that? Well, sometimes it can cause a hydra that stays around for a while. And so sometimes what may need to happen with these is that you do an EVD, but guess what may happen in the long term? You may need to actually have kind of a long-term shunt between the ventricles to the peritoneum, because it's just taking so long from those arachnoid granulations, or they're kind of like destroyed in some way, from trying to drain that blood from the subarachnoid space. And sometimes they may need what's called a ventricular peritoneal shunt, or a VP shunt, okay? And so that's something to think about as well. So we got ABC, EVD. What else? Well, here really quickly, since we're already at this point now, we're monitoring the ICPs with the EVD. We already said that if the ICPs are saying sustained, they're greater than 20 millimeters mercury for a long period of time. Why am I stressing on the sustained? If you cough, your ICPs go up. If you are in pain, your ICPs go up. If you have a fever, your ICP goes up. If you're having a bowel movement, your ICPs go up. So after those kinds of events, let them calm down. Treat their pain. Let them calm down and stop having bowel movements. Let them stop coughing or treat the coughing in some way, shape, or form. That'll reduce their ICPs. If the ICPs are sustained despite those measures, what do you do? Big thing to think about here. First one, make sure that the neck is midline. This may sound so stupid, but it's very important. If the neck is midline, you're allowing nice venous drainage. Keep the head of the bed elevated at 30 degrees. If your head of the bed is elevated, that allows for gravity to pull the blood down from that venous system. The next thing, some people will say hyperventilation. You have to be very careful with that because you increase the risk of stroke. But sometimes we do allow for permissive hypercapnia, but you just have to be careful. Remember, this is only a temporary measure. You don't want to do this for very long. The next thing that you would do is you could give things like mannitol. Mannitol is basically an osmotic agent, yanks water from healthy cells and helps to dehydrate the brain, shrinking the brain size. If you shrink the brain, it's one of the 3 components that can decrease your ICP. The other one is you can give hypertonic saline, and there's different types of hypertonic saline. If you want to give something that you really want to acutely change, you give something called 23.4%. If you want to do it over a longer period of time, you give 3% hypertonic saline. Same concept as mannitol, makes the blood really salty and pulls water from the healthy cells of the brain tissue, dehydrating it, shrinking the brain size. Okay? But these are the measures that you will take whenever there is elevated intracranial pressures, along with the EVD, hopefully draining some of the blood in the CSF from those ventricles. All right, we talked about that. Let's move up into the next part of our treatment process. All right, engineers, so we did ABC, EVD, controlled their ICPs. Next thing is coiling clipping. Very, very important. This has to be done within the first 24 hours of these patients arriving to the hospital. Very important to get this done. If you don't coil or clip or just basically secure that aneurysm, it can continue to keep bleeding, or they have a high risk of a rebleed, which is almost a 70% mortality rate. So very significant there. Now, question that comes here is, what the heck, which one do I do, coil or clip? I don't want you to get too bogged down in the details. This is where the interventionalist will actually be more involved, but coiling is a little bit more particular, so it kind of depends upon a couple factors. So one is we say age, and the other one is we say the neck of the aneurysm, so the neck of the aneurysm. The third thing is if they have, their hemodynamics, and then the last thing is the location of the aneurysm. These are kind of the ways that we determine them. So for coiling, it's been seen, studies have shown that it's better for older. Clipping is better for younger. Now, coiling is you're literally taking kind of like these coils, endovascular, you go to IR, they go in there and they stuff all these coils into the vessel and basically prevent that vessel from being able to bleed. Clipping is they actually open up the skull and then kind of go around wherever the vessel is and put a clip at the base of it, or that neck of where the aneurysm is. Okay? So we have older, younger for coiling versus clipping. The neck. For this one, you got to stick coils into this area. If that neck is really big, the coils could just fall out, right? So we want this, we prefer a smaller neck. So small neck. This one, it doesn't matter because you're clipping it at the neck. So if they have any size, a big or small, it's preferred. But let's just make it easier here, and let's say a large neck, so that it's easy for us to remember. The next thing, hemodynamically. Coiling is actually better when they're hemodynamically stable in this kind of situation, hemodynamically unstable. So hemodynamically unstable, they have cardiopulmonary complications of some kind. Coiling is actually preferred. Clipping is better when they are not hemodynamically unstable. We prefer that they be as hemodynamically stable as possible to get clipping done. Okay? And then last but not least, location. Coiling can occur anywhere. It doesn't matter. We can put any vessel, but it's most preferred when it's the vertebro-basilar vessels. So the vertebro-basilar system, okay? Clipping is best whenever it's the MCA, the ACA, and the ICA terminus. Okay, those are the best or preferred points for that one. So coiling, clipping, big thing, has to get done within the first 24 hours. What do we pick? It depends upon age, neck, hemodynamics, and location. Boom, let's move on. We've secured them with a coil or clip. What is the next biggest complication that we have to watch out for with these patients? It's rebleeding. Rebleeding has a 70% mortality rate, and this can occur really at any time when the patient's in the ICU. It's most high risk usually within the first 24 to 48 hours, but it can extend up to 2 weeks. Now, let's say that a patient is either secured or not secured, doesn't really matter, and they rebleed. If they rebleed, what do you do to try to stabilize that until you can get them back in and recoil or clip or revise that coiling or clipping? So we need to talk about the treatment that's temporary. So sometimes what you will do is you'll give medications that will stabilize the fibrin mesh. Okay, so whenever you have this rupture of the vessel, your platelets are going to try to come to this area and clawed off that injured area. And then fibrin's gonna try to come and stabilize that actual platelet plug. Well, what we wanna do is try to keep that platelet plug as firm as possible and stabilize the fibrin within that structure. And we can utilize drugs to help with that. One of them is called aminocaproic acid. And the other one is called tranexamic acid, also known as TXA. Okay, so you can give these medications to help to stabilize the fibrin mesh. What is important to remember though is that these have high risk. Whenever you give these medications, it'll try to stop them from bleeding, but it's going to increase their risk of clot. So if someone has a history of coronary artery disease or peripheral artery disease, you better be very careful because you could cause them to have an MI or an acute limb ischemia if that happens. So think about that as well. It has to be taken into consideration. The other thing is you can also replace the fibrinogen. So if I want to replace some of the fibrinogen to help make more fibrin mesh, I can give a drug that will help to kind of replace the fibrinogen, and that is called cryoprecipitate. Okay? And then lastly, sometimes if you're consuming a lot of these platelets within that, you can also potentially have risk of low platelets. And so if there's low platelets, what do? You give them platelets. So you transfuse them to a particular goal, usually a goal, sometimes it depends upon the patient, but preferably greater than 100,000, okay? So rebleed, high mortality rate. What do? We have to go back in. What's the ultimate goal? The ultimate goal, this is the temporary, but the ultimate goal is revise, coil, clip. But in the interim, to stabilize that fibrin mesh until they can go and do that, aminocaproic acid, tranexamic acid to stabilize the fibrin mesh, replace the fibrinogen to help to form fibrin strands by cryoprecipitate, and if they're low in platelets because you're consuming them, you give them platelets. Okay, we talked about coiling, clipping, rebleeding. The next thing that I want to talk about is vasospasm. All right, vasospasm, delayed cerebral ischemia is a very important complication to remember with subarachnoid hemorrhage. So with vasospasm, what happens is you have this vessel that actually ruptures, right? So there's your aneurysm that ruptures. When it ruptures, what happens is you release a lot of inflammatory. There's a lot of inflammation that occurs. A lot of inflammatory mediators are released. And these inflammatory mediators or vasoactive substances can cause vessels within the circle of Willis to start clamping down and squeezing. And as you clamp down and squeeze on this vessel, it's going to narrow. If you narrow that vessel, what can that do as you clamp down on it because of causing it to spasm? Well, what happens is you may decrease the blood flow to a particular area of the brain. If you decrease the blood flow to a particular area of the brain for a long period of time, this can lead to ischemia. And if that ischemia occurs and it's prolonged and you haven't been able to reverse it, what can be the problem with that? Well, ischemia that is untreated can then progress to infarction. And so they can actually stroke, okay? That's a big thing to remember here. So vasospasm, delayed cerebral ischemia is vessel ruptures, inflammatory chemicals are released, vasoactive substances are released, causing those vessels in the circle of Willis to kind of like squeeze and squeeze and squeeze, causing spasming, narrowing those vessels, decreasing the blood flow to particular areas of the brain of whatever vessel it is, leading to ischemia to that area, and then if not treated, infarction, where they actually develop an acute ischemic stroke. It's important to remember that vasospasm occurs most commonly on days 4 to 14 after the subarachnoid hemorrhage. Now, this is a serious one. So this one has a very rebleeding high mortality rate. This is the second one for mortality. So how do we basically monitor for vasospasm? Well, we do it through two ways. One is you can do what's called daily TCDs, which are called transcranial Dopplers. And what these do is they determine the velocity of blood flow that are moving through these vessels. Remember your physics. What does physics say? Physics says that as you decrease the kind of the diameter of the vessel, what would that do to the velocity of that vessel? It would increase the velocity. So if you make kind of a little pipe smaller, it's going to flow faster through it. So it's going to increase the velocity. So what we would expect is, as we measure their transcranial Dopplers, the velocity of the blood flow through those vessels, if they're having spasm, what would the velocities look like? Higher or lower? It would be higher. And so what we're looking for is how high, really. We want this to be greater than 120 centimeters per hour, up to greater than 200 centimeters per hour. That is indicative of vasospasm. Now, the vessel that this actually looks like through research is this actually utilizes the MCA, but this can somewhat apply to all the other vessels. The other thing that we look at is what's called the Lindegaard ratio, which takes the MCA over the ICA and gives you a ratio which helps to support if this is truly vasospasm. If it is greater than 3 to greater than 6, this is also suggestive of vasospasm. And again, this is called the Lindegaard ratio, which takes the MCA velocity over the ICA velocity and gives you a particular number. If it's greater than 3 to greater than 6, it's indicative of vasospasm. The other ways that we can monitor, so that's one way. One way that we can monitor is through daily TCDs. The second way that we can monitor that is what's called a CTA, where you literally take and go and visualize, push contrast through the vessels and look to see if the vessels are narrow at certain points within the circulation. That could be another way. Regardless though, what is the treatment for these situations? So when someone has vasospasm, it's kind of may seem a little odd, but we treat them by first trying to reduce vasospasm by relaxing the vessels. And so what we can try to do is to relax those vessels or dilate those vessels. We can give something called nimodipine. And so nimodipine is a calcium channel blocker that will try to dilate or relax those spastic vessels. It's been shown to reduce some of the severe outcomes associated with vasospasm and like mortality. The second thing that we can do is we can cause induced hypertension. So we already have very little blood flow. Let's increase their blood pressure so that we can push as much blood through those narrow vessels. So induced hypertension is another thing. And what we do is we aim for a systolic blood pressure of like 160 to 200 millimeters of mercury. So we can really push as much blood in those vessels as possible. And so sometimes you may have to use things like vasopressors, like norepinephrine, or phenylephrine, or you may even have to use inotropes, pure inotropic agents like dobutamine and milrinone. The third thing that you'll want to do here, besides trying to relax the vessels, induce hypertension, is intra-arterial dilators. So you actually take them to interventional radiology, they thread a little catheter, and they spray little types of arterial dilators into the area. Things like verapamil, things like milrinone, things like nifedipine, and so on and so forth, trying to really dilate those vessels and stop them from spasming. That is the way that we try to monitor and treat vasospasm to reduce the risk of strokes, which can worsen their already terrible prognosis if they have high Hunt-Hess scores. Okay? Oh, and real quick to see if you guys remember, what was the score that can determine their risk of developing vasospasm or delayed cerebral ischemia? It was called the modified Fisher score, which we used from our CT. Let's see if you guys remembered that. All right, the next thing to think about with subarachnoid hemorrhage is they also have high risk of seizures. And it's very simple. As you have blood in that subarachnoid space, what is that doing? That's touching the cerebral cortex. That's where your upper motor neurons are located, right? That's where the cell bodies of those neurons are located. If they become agitated by the blood, they can start firing and triggering this abnormal, excessive, kind of synchronous electrical activity leading to seizures. And this can present in a bunch of different ways. This can present as a focal seizure, depending upon the area where maybe the blood is most concentrated. Or maybe it can cause a generalized seizure, where like they have a tonic-clonic seizure. And sometimes they may not even present with any visible signs of a seizure, and they present what's called non-convulsive status epilepticus, where they just have declining mental status and other abnormalities that you only can really pick up their seizure activity on a continuous EEG. So sometimes you may need a EEG to determine if the patient is truly kind of seizing. But either way, the best thing to do is to treat these patients with anti-epileptic medications, okay? The next thing is pyrexia. Believe it or not, this is a very common scenario, a very common situation that arises with subarachnoid hemorrhage. It's very simple. Blood within that subarachnoid space can irritate the hypothalamus. And what happens is, as you agitate that hypothalamus and tick it off real good, it's going to try to increase your body's temperature and lead to these really nasty fevers, pyrexia. So what do we do to try to treat this? And the other question is, why do I need to treat this? Because fevers, guess what this can do? It increases the risk of vasospasm. You know what else fevers can also do? They can also increase intracranial pressure. So these can become really problematic whenever you're febrile. We don't want that. So we want to try to get rid of these fevers or this pyrexia. And so the ways that we do this is we use cooling measures. We're not going to go through all of them. The ones that I want you guys to remember is it's very simple. What can I do? Put a cooling blanket on them. I could do what's called an Arctic sun. That's a common one that is utilized, an Arctic sun. Another one that's a commonly utilized one is what's called a Zoll catheter. You actually take a catheter, thread it into a subclavian vein or an IJ, and what happens is it has cold water running through the catheter and through this coil that cools the blood. So that's ways that you can do that. You can also just give cold infusions. So cold normal saline infusions. Now here's the problem. When you try to cool them down through these measures, guess what happens? Their natural reaction to you trying to cool them down with these measures is shivering. And when they shiver, guess what they're going to try to do? They're going to try to compensate for that, and they're going to basically counteract everything that you're trying to do. If they're shivering, they're basically creating an adaptive homeostatic mechanism to bring their body temperature back up, which is a problem because we want to bring it down. So what we have to do is we have to decrease the shivers. And how do we do that? There's so many medications. I'm only going to list a couple. You can give things like magnesium. You can give things like buspirone. You can give things like bromocriptine. You can give things like propofol. You can give opioids like meperidine or fentanyl. And worst case scenario, you may have to just shut down their muscles and all and paralyze them so that they stop trying to compensate and shiver. So these are very important things to think about. The next complication, as if there wasn't a million already with subarachnoid hemorrhage, is cerebral salt wasting. Whenever they have that hemorrhage, it triggers a release of epinephrine, norepinephrine, and what happens is that epinephrine and norepinephrine, so here we'll say like epinephrine and norepinephrine, what that does is that triggers your heart to release what's called atrial natriuretic peptide. And that atrial natriuretic peptide acts on the kidneys. And what it does is it inhibits aldosterone and ADH. What does aldosterone do? Reabsorb sodium and water. If you inhibit that, what happens to the sodium and water? Ends up dumping into the urine. It also inhibits ADH. What does ADH do? Reabsorbs water. If you inhibit ADH, what are you going to do? Dump water into the urine. So what happens is they cause hyponatremia in the blood, and it also causes low water volume in the blood. Okay, and so that's called hypovolemia. So you can develop hyponatremia and hypovolemia. Why is hyponatremia bad? Hyponatremia is bad because guess what? It can worsen cerebral edema. Because if the actual blood is really less salty, now what happens is water will actually move from the blood into the brain tissue, worsening cerebral edema, worsening intracranial pressures. Why is hypovolemia bad? If the person's in vasospasm and you have hypovolemia, what do you do to the cerebral blood flow? You decrease blood flow, and that can also worsen vasospasm. So how do I treat cerebral salt wasting? I inhibit the atrial natriuretic peptide. So I treat them by giving them a drug that will oppose atrial natriuretic peptide. I give them aldosterone, but we give this in the form of what's called fludrocortisone, which is basically aldosterone, so it's going to reabsorb sodium and water that AMP is trying to cause you to get rid of. I also can give them back sodium and water. How do I give them back sodium and water? I can give them back sodium and water, so give sodium back with the water. I can give them normal saline infusions. I can give them 3% hypertonic saline infusions, or I can just give them salt tablets. And either way, I'm going to try to get that salt back up and try to get that volume back up. And that's the big thing to think about here. Ninja Nerds, we're at the last part of the complications: stress cardiomyopathy and neurogenic pulmonary edema. This usually happens in day 1 or 2, okay, of subarachnoid hemorrhage. Upon day 1, day 2, when there is that hemorrhage, it causes a massive surge of norepinephrine and epinephrine. And what that does is that puts lots of stress on the heart muscle. Causes the heart muscle to become so stressed, guess what happens? It can become slightly ischemic. Okay? It can also decrease the ejection fraction. So now they develop low cardiac outputs, which can lead to hypotension. And it also causes apex ballooning. Okay? Very weird kind of situation there. So, with stress cardiomyopathy, what happens is hemorrhage occurs, massive amount of catecholamines like epinephrine, norepinephrine are released. Whenever that happens, it puts a lot of stress on the heart, which leads to ischemia. It can lead to the heart becoming stressed and having a decreased ejection fraction, cardiac output, hypotension, and it also can cause the apex to balloon. You know what they call this stress cardiomyopathy? Another name for it? Takotsubo cardiomyopathy. You know what's interesting is they can present with ischemia. So if you look at their actual EKG, their EKG will show ST segment elevation. They'll have a troponin leak. So their troponins will be positive. You'll look at their echo, and it'll show decreased kind of like global hypokinesis of the muscle. But what's big kind of identifier here is that there's ballooning of the apex. Okay? So that can happen in this scenario. How do I treat that? Well, I treat this by giving medications that'll actually increase the cardiac output, because the problem is I can become hypotensive. So how do I do that? I give them things that'll actually increase their MAP or their cardiac output. So I can give them things like vasopressors or inotropes. So things like norepinephrine, dobutamine, milrinone, so on and so forth. What's the other complication? Again, the other complication is from that massive catecholamine storm, you release lots of norepinephrine and lots of epinephrine, and what that can do is that can act on the vessels and cause these vessels to become kind of permeable and leaky within the pulmonary system. If they become leaky, guess what happens? some of that fluid, the plasma, leaks out into the interstitial spaces and into the alveoli, leading to pulmonary edema. And that fluid that accumulates around the lungs can cause hypoxia. So now they can have difficulty breathing as well as hypoxia. So what can they have? Hypoxia and dyspnea. And then if you look at their chest x-ray, it's going to look all pulmonary edema-like. So that could be one reason, is because of the catecholamine surge causing the leaky capillaries. But what else could do it? If someone has Takotsubo cardiomyopathy or stress cardiomyopathy, and their left ventricle isn't pushing as much blood out, where can that blood kind of backflow? From that left ventricle to the left atrium to the pulmonary capillaries, from the pulmonary capillaries, it can leak out into the interstitial spaces. So not only could the neurogenic pulmonary edema be due to the catecholamine surge, but it could also be from Takatsubos. And so how do we treat these? Well, you have to address the hypoxia. There's a lot of fluid there. So the way that we treat this is increase the PEEP, because PEEP will help to get rid of a lot of that edema, and increase FiO2, oxygen percentage, so that you can get as much oxygen into the alveoli to push across the lungs. And the other thing is, give them things that'll increase the left ventricular cardiac output. So giving them things like vasopressors and giving them things like inotropes will address the problem if it's the stress cardiomyopathy that's related to this edema. Okay? Ninja Nerds, that covers subarachnoid hemorrhage. All right, Ninja Nerds, in this full-length feature film on subarachnoid hemorrhage, we cover so much information that I hope it helped. I hope it made sense. As always, Ninja Nerds, until next time.